Welcome back. And let's now turn our attention to how illness can impact on our mental health. And to moderate our first roundtable this afternoon, we have the pleasure of being to welcome the moderator, the oncologist and hematologist, Dr. Alain Herrera. Alain, lovely to see you this afternoon. Over to you.
Thank you, Alison. So, good morning, good afternoon, or good evening to all our attendees. I'm very pleased and privileged to moderate this first roundtable dedicated to the impact of illness on mental health. As a treating physician, managing patients with incurable diseases like hematologic malignancies or cancers, I have often been confronted with the problem of the impact of illness on mental health, or, on the contrary, that of mental health on the occurrence of the illness and how to live with it. And I think the following sentence from the French writer and philosopher Albert Camus can help to face and to understand this dilemma. Camus was saying, man is the only creature who refuses to be what he is. How does one decide what is worth existing or fighting for? It's common to feel sad or discouraged after an heart attack, being diagnosed with cancer, or trying to manage a chronic condition like diabetes, lupus, or multiple sclerosis, for instance. But when these symptoms persist, they can cause depression, which will affect the ability to live daily life and to enjoy family, friends, work, leisure. The health effects of depression go beyond mood and feeling of helpless rebellion. Depression is a serious medical illness with many symptoms, including physical ones. If it may come as no surprise that people with serious medical illness are more likely to experience mental health condition, the reverse is also true. People of all ages with depression are at higher risk of developing certain organic illnesses. People with depression have an increased risk of cardiovascular disease, diabetes, stroke, pain, and Alzheimer's disease, for example. In all cases, the coexistence of an organic illness and a mental illness creates complex situations and impact the treatment of both conditions. Then, to discuss these topics, we brought together several stakeholders in the different relevant areas. And today, our first speaker will be Mrs. Maria Nassif. Maria is an homozygous familial hypercholesterolemia patient and familial hypercholesterolemia Europe patient ambassador. She is Lebanese, living in France, and she was diagnosed at the age of 3. She will share with us her experience on how to live on a day-to-day basis with HoFH and how the disease impacts her mental health. Then, Mr. Frédéric Destrebecq, the Executive Director of the European Brain Council, will explain the European strategic directions and how the relationship with the member association and other stakeholders are managed. Frédéric will be followed by Silvia Muñoz. Silvia is a dedicated psychologist working at the Psychiatry department at the Research Institut Vall in Barcelona. In addition to her dedicated focus on fetal alcohol syndrome, Silvia has also been actively involved in the EU-funded research project named Discovery since 2021 aim at unraveling the intricate connections between irritable bowel syndrome and depression and anxiety. The last speaker will be Mr. Rodrigo Antunes Lima. Rodrigo, is a researcher at Parc Sanitari San Juan de Deu and a member of the Centre for Biomedical Network Research on Mental Health, CIBASAM, in Spain. He is the coordinator of the IMPROVA project, and his main focus is on promotion of mental health and prevention of mental problems in children and adolescents. So I will now leave the floor to Maria.
Yes. Hello. First of all, thank you for having me between you in this event as a panelist to talk about my disease, the HoFH, homozygous familial hypercholesterolemia, especially that we have celebrated the first HoFH Awareness Day this year on 4th of May. So as Alain has mentioned, I was diagnosed at 3 years old when xanthemas has appeared on my body, which made my pediatrician run many blood tests to confirm that I have HoFH. I have started to take my medicine at 4 years old and LDL apheresis at 6. In my late teens, my medicines were upgraded to statins and ezetimibe, and echocardiographies, echodopplers became a yearly checkup. Everything seemed fine until at 24 years old, I have underwent an open heart surgery, which was a big shock for me and hard to accept, especially that I didn't get any warning or alarming notification from any healthcare provider. HoFH is uncertain. And my older brother he had the same exact story as mine and was already in France for his study, told me to join him because in France they have a better treatment, it is more efficient, and healthcare professionals are more considerative. So I have joined him, and indeed my health has improved drastically within only 2 years doing treatments. LDL-C level got decreased from 600 milligrams per deciliter to 200 milligrams per deciliter, and 90% of xanthemas on my body has disappeared. HoFH impacts our daily life from physical, psychological, and mental level. First of all, the treatment that we take that includes medicines, healthy food diet that includes fat, and the LDL apheresis should be consistent, and you should be committed to have them. It is a big effort to keep up with all of these mandatory things that we should do with our lifestyle. In addition to that, doctor's appointments, yearly checkups are all equally necessary to check that we are healthy. All of these treatments and appointments should be organized with our daily lifestyle, and it's a huge life management exercise to do to be able to fit all these appointments with especially my work projects and meetings. Second of all, since I have atherosclerosis, I have oftenly a feeling of chest tightening, racing heartbeats, fatigue, even, how to say it, shortness of breath, which equals symptoms of anxiety. And that's how my brain goes into a vicious circle, not knowing if I'm having a heart issue or an anxiety attack, which gets me into an overwhelming overthinking and gets me into a freeze mood and then lead into depression. Second of all, HoFH has impacted my relationship with my parents. Since I was a kid, it is my parents who took care of me, my health, who has put fear into me to eat only food that don't have fat and take my medicine every day. They have banned me to eat, for example, when I go to other kids' houses. Whenever I go to my friends or family, I have always a fear and scared to what I should eat or not because I didn't know what my disease is. No one explained it for me. In my late teens, when I wanted to be more independent, I started to research about my disease. And that's when I found out I have a chronic disease, an illness that will live with me for all of my life and I have no control over. That's where I labeled myself as a sick person. And for me, sickness equal weakness, equal defected. This has impacted my self-image and self-confidence. Added to that, the xanthomas that I have on my body made people sometimes run away from me, scared that this yellowish deposit that I have on my body that are visible, especially on my elbows and my knees, gets them scared that it would be contagious. But before I can get the education, I didn't know how to explain for them that they are not contagious. So I grew up feeling isolated, feeling lonely, with the low self-esteem, low self-confidence, and not having lots of friends. In adult years, especially when I moved to France, with all of the screenings that they have did to me and tests, my cardiologist told me that I should get back from doing high-effort activities and start to do low-level activities, low-effort activities. And as in my 20s, I enjoyed to do gym, dancing classes, go on hiking, and telling me that I should stop enjoying all of these activities has put me in a big episode of depression. And I have done a lot of mental and internal effort to go out of this depressive episode and to accept my condition and eventually to...
All right, we have perhaps a
negative effect on my heart.
Joan. She's back. Go ahead. Go ahead, Maria.
Okay. Do I have a problem?
Please go ahead. We are listening to you, and please go ahead. We had just a quick freeze on the screen.
Ah, okay, sorry.
No problem at all. Please continue to tell us your story.
Okay. So all of these can have a huge impact on our mental health, especially with anxiety and depression. Not only does HoFH impact our daily life in the present, but also our choices for the future. For example, choosing our partners and friends. Not only they should be trustworthy and supportive, but also they should be accepting and understanding of our condition with the scientific meaning and to know how it affects our daily life. For example, my partner should be understanding that sometimes I won't be able to move, I won't be able to do the minimum bare chores of work at home, like cleaning or cooking or etc. Second element that HoFH affects is the choice of having a baby. In my opinion, it is unfair to choose to have a baby knowing consciously that they will have one of my mutated genes and get sick and have eventually heterozygous familial hypercholesterolemia. In addition to that, they will have a mother who can't keep up with their activities at school, and I will be afraid that my anxiety and depression will affect them as well as young as they will be. The HoFH can impact the work activity. I have very limited choices to choose the work I want to work with, the job description, and check if it requires a high effort activity. If it does, I can't choose it. It's the choices that affect are the ones for the activities I do with my friends, where always have to check, have a low-fat food menu. The activities we are doing are not tiring for my body nor my heart. It's always this disease has put in us a sense of fear, of depression. And this story isn't only mine. Many patients with HoFH have same story and are suffer from anxiety and depression. For that, in conclusion, I want to
Maria, we are,
six,
unfortunately, Maria, we are having one or two technical issues, which is making it very difficult for us to not only hear, but see you. We hope we're going to be able to sort this out, especially to be able to join us again for the discussion with Alain and the fellow speakers in your panel this afternoon. We're so sorry about that, but this is what happens when we go out live. Let's see if we can join perhaps our next speaker in the panel, Alain.
Yes.
It should be, I believe, Frédéric Destrebecq.
Frédéric Destrebecq. Right? So, Maria, thank you, and I hope we will have later on the opportunity to hear from you and to have your participation to the panel discussion. So now we move to Frédéric.
Yes, hello, good afternoon, and thanks a lot for having me. So my name is Frédéric Destrebecq. I represent here the European Brain Council, which is an organization based in Brussels. I would say specialized, so to say, in advocacy work to EU institutions to promote brain research, brain health, brain science, and the brain capital within EU affairs. And we represent patient organizations, clinical and scientific societies, as well as the private sector to really build consensus and develop our activities. I'm really pleased to join the panel today because we are really convinced, and you will have understood by explaining, let's say, our DNA, that we are strong believers of patient-centeredness and let's say, patient centricity whenever advocating and developing solutions to improve health outcomes for those living with a brain condition. And it is particularly important not only because of the burden of the disorders of the brain to society and to our economy. So we estimate that it is more than 1 in 3 Europeans that live with a neurological condition and 1 in 4 living with a severe mental disorder. And I think Maria also expressed the way by which some disorders also impact our central nervous system, but also how comorbidities actually would develop, and particularly in our example with the depression and anxiety. And we see also the fact that within the brain space, there is a very strong interrelation between, let's say, the neurological and mental tropism of diseases. So that really brings me to my second point, which is the inherent complexity of brain disorders, but also of brain science and brain research. So not only in understanding the diseases or working on the etiology of diseases, but also in understanding the healthy brain functioning. And this is posing, let's say, issues transversely that obviously are really key in our advocacy work at EBC, but it's really mainly in knowledge generation, in how we translate this knowledge into optimum solution, but also how we foster the generation of innovation to address patients' unmet needs. And in doing so, as I said in the introduction, we are strong believers of the need to receive the input of experts by experience, as we would very often call patients. But it's not only a belief, it's really also a demonstration of the added value that this is providing. And I'll come to the notion of patient-reported outcomes in a moment, of patient-reported experience. But when we say expert by experience in our language at EBC, it's really to really have the need to care and the need to focus and the need to look after the persons that would need it the most, i.e. patients. But it's also a philosophy that enables us to bring together other experts by experience, and I would say the professionals looking after them, the clinicians looking after them, but also the researchers that actually are looking after finding the solutions, maybe not for today or tomorrow, but for the moment by which these can be translated to patient bedside. And that's also why we have at heart to include the private sector in our work, because this is really having this continuum of all the tiers and all the interested parties in the value chain that will enable us to provide the best solutions. So when it comes to tech and innovation, we believe that there is probably here a gap or an unmet needs that we need to address, which is very often crafted around the need or the tendency to involve end users in the primary design of those solutions or those innovations. But then we tend to forget end users as those solutions gets developed. So we have, let's say, an early engagement, and then very often we tend to forget about the end users until the moment that innovations need to hit the market or be submitted for a regulatory appraisal. And all of a sudden we realize, oh my God, yes, indeed, we need to get back to the end users because they need to help us demonstrate to regulators or to payers or to whoever is going to use our solution that this is really of value. And there is often a waste in the system in terms of resources, time, obviously also budget indirectly, but that this whole process of engagement needs to be let's say restarted. And it's really a pity because we contributed as EBC in different projects that really captured and demonstrated the value that this engagement and thorough engagement across the board in not only patient-reported outcomes and patient-reported experiences, I said, in clinical trials, but also in the design of research or innovation impact. So this is definitely something at EBC that we are prone to defend. This is why we have entered into projects such as the ones that I just mentioned, but we are also actively engaged into organizing platforms for this kind of collaboration and dialogue. One example is the organization of the Brain Innovation Days, which is now becoming an event held on a yearly basis in November. So this year we will have in Brussels the Brain Innovation Days from the 12th to the 14th of November. You are all obviously warmly welcome to join, because we really would like to not only mobilize our community, as I said, patient researchers, clinicians, and the private sector, but also having startups, innovators, funders, regulators, policymakers. I mean, basically anyone for whom brain innovation means something, but also anyone who actually is committed to addressing the challenges to making innovation a concrete reality in Europe. A second initiative that we are defending is the coordination of a European Charter for Ethical Principles for Neurotechnologies. This is based on an initiative that was taken in France and actually mobilized by the French Ministry of Research. But we were actually contacted via our European organizations to really say, okay, we need to scale this up at a transnational level. Hopefully one day we can have this discussion globally, but let's start at a European level, because working from a country-specific approach doesn't make any sense in our highly technological environment and era. So this is something that we are currently busy with. And we hope to be able to launch the charter on the occasion of the Brain Innovation Days. And then the last initiative, and I'll finish there, is actually a very recent development, not later than yesterday, was launched in Brussels, what is called the European Brain Health Data Hub. It's an initiative that has been taken by a few of our national brain councils. So national brain councils from Belgium, France, Greece, and Germany and Croatia that actually wanted to work together in and helping patients getting fully empowered in the decision-making of what needs to be done with the data that actually is being processed about them. And the issue here is really to create a system of trust where where patients actually have the full control in that sense, and is working really under the basis of a declaration that was made in the occasion of one of our events. President of a patient federation came in the European Parliament and had these very bold statements that I would never probably stop quoting, but it's stop overprotecting us. That there is this tendency of looking at health data purely under the prism of data protection and privacy, but there is also this willingness from a lot of patients within the community to say, look, we would like to decide by ourselves what is being done, and if this can advance and help research and innovation, we would like to be able to decide that this is being done and that nobody else does. And the second great innovation with that Brain Health Data Hub is the fact that it is using an article under the Data Governance Act adopted by the European Union, which is the creation of an altruist association. So that means that it is being done for a non-commercial purpose. And this is probably the first initiative of that kind at the EU level. And this is coming to my conclusion, which is in the context of patient-reported outcomes, patient-reported experience. We see the value of it, but we see also that there is still the need for clinical validation of the wealth of, and I would say the added value of this kind of data can bring in the system. And we are very much hoping that with those latest developments, we can contribute to this validation and maintaining that healthy dialogue from within the community. So thank you for your attention and happy to receive any questions.
Thank you very much, Frédéric. And now we move to the third speaker, to Silvia. Hi. Silvia, please, the floor is yours.
Hi, and first of all, thanks for inviting me. And it's lovely to share all these talks with you. So I'm here to explain a little bit about our project in Vall d'Hebron hospital in Barcelona, which it's called Discovery. And Discovery stands for Development, Diagnosis and Prevention of Gender-Related Somatic and Mental Comorbidities in Irritable Bowel Syndrome, right? This is a project that is coordinated by Vall d'Hebron and is funded by the European Union. So it's a 5-year project, and I have been actively involved since 2021. And we are just finishing the recruitment, which I have been more directly involved with. And the objective of this project is to provide an enhanced understanding on irritable bowel syndrome and together along with mental diseases such as depression and anxiety, as well as somatic like fibromyalgia and chronic fatigue. And so the study now is coming to an end of the recruitment. Like, let me put the context of irritable bowel syndrome. It's a common and chronic functional gastrointestinal disorder, which is characterized by abdominal pain, excess gas, diarrhea, constipation, and is mainly observed in young females and mid-aged females. So it constitutes like 50% of the outpatient gastroenterology workload, which is quite a lot. And the problem with IBS right now is that lots of the patients, like 60–70%, that come to visit with presenting IBS symptoms, they also present clear, or they manifest the presence of mental or some somatic comorbidities in addition to these debilitating gastrointestinal symptoms. So the aim of the study, basically of discovery, was to understand the similarities and differences among patients with IBS, with or without comorbidities, right? And demonstrate the mechanisms underlying the differences and similarities. Like in order to achieve this, the target was, Hebron is coordinating this project, but we work together with 9 more centers across Europe. So the target was to recruit 800 participants. So it is quite a big project, and to collect demographic, clinical, psychosocial characteristics of the patients, as well as lifestyle factors, and also with biological samples, collect mechanisms of intestinal, central nervous systems, and the interaction with the peripheral microbiota and gut axis. So basically, what I was, my task, my duty in the study was to recruit patients. And out of the 800, well, first of all, it was we recruited like 300 patients were selected for the cross-sectional study, and then 500 were part of a longitudinal study, right? And from the longitudinal study, they came to baseline, and then they came a year later for the first follow-up visit, and then a second year later for the second follow-up visit, right? And they built the recruitment, like the subjects were characterized by a clinical interview, which was done, I did for them, and following clinical routines and using a case report form during the interview. So I collected through a platform which was designed for this study. We collected demographic, disease-related information, health history, medication, hereditary factors, infections, and lifestyle data, along with the diagnostic criteria, right? So they also worked for a month an e-health, which was like a watch, a e-watch, and this monitor their sleep and their heart rate as well. So furthermore, all the patients in baseline follow-up 1 and follow-up 2, they all completed different questionnaires to assess the severity of the symptoms of IBS, mental, somatic, and there was also a group of healthy control subjects which did exactly the same, basically. And so also there was samples, biological samples were collected. And in the baseline, we had, in order to assess the patients with IBS symptoms, to assess the structure of their mucosa in the gut, they had colonic biopsies done. They also had like stool samples. They also provided patients with urine samples to test their permeability, in as well as blood samples. And from those blood samples, it was isolated in order to test the genomic DNA of the samples, basically. So all in all, we tried to make a really complete project that included not only like the biological, symptoms of the person, but also we assessed through the questionnaires and through all these interviews and, all with validated questionnaires, their experience, their day-to-day experience of these patients. And basically the inclusion, the criteria, they had to be over 18 years old, they all signed consent form, and they came in visits twice, first to an interview with me in which I administered the psychiatric interview to see where they were in psychiatric terms, and if there was any other disorders which could be observed besides anxiety and depression. Those those patients had to be excluded as the groups of patients that we included were either IBS alone, like patients who presented irritable bowel syndrome symptoms alone and who were diagnosed, or we had also IBS with mental, such as anxiety and depression, and we also had somatic patients which also presented IBS with fibromyalgia of chronic fatigue. Then we also had patients who only had mental disorders diagnosed, such as depression and anxiety, and then we also had the healthy controls. So it was a very inclusive project. We are now in the process of analyzing the baseline of the 800 participants, and the tendency that has been shown, it's been observed a really significant, moderate to a strong correlation between those patients who presented IBS symptoms with those presenting mental health conditions such as depression and anxiety. And it was also observed that lots of these patients presented also post-traumatic stress disorder, and there was a big correlation to this. So we are in the process now of analyzing the second visit and the follow-up, too, and hopefully we'll be able to provide more of this data once it's finished. And I think this is the first actual project funded by the EU, which contemplates irritable bowel syndrome and tries to establish a correlation with mental health disorders such as anxiety and depression. And yeah, from my point of view, it's it's been a really truly interesting insight to see how these patients, how the mental health has been impacted and has added to this condition already of IBS. So, so please, I'm also open to any questions regarding the project.
Thank you, Silvia. So now we will move to our last speaker, Rodrigo. The floor is yours.
Thank you. It's a pleasure being here. Thank you for having me. So I would like to talk more specifically about mental health promotion in youth, in children and adolescents. And actually, this age range is very important for promoting mental health for many reasons. For instance, if we are just talking about psychological distress, like feeling of belonging, this already has an important impact on school failure and skipping school, and this actually has big impact later on in life. So people who have adolescents who have any psychological distress, we are talking about mild psychological distress, they are less likely to have higher education, and that has big impacts on their income, socioeconomic health, which is highly related later in life with health in general, quality of life, and many other aspects of life, and actually earlier mortality. So child and adolescent mental health actually impacts later on in adulthood. And if we are talking about other mental health problems like self-harm, depression, anxiety, or eating disorders, then those are some of the highest risk factors for decreased quality of life in youth all the way to adulthood. and the numbers are quite striking. 75% of people who have any mental health problems, so an anxiety attack or a depressive episode, actually these 75% will have the first episode before the age of 24. And every time, once you have the first episode of any mental health problem, actually the likelihood of having another problem, so recurrence of a mental health problem, it's all the way up to 80%. And that has high impact throughout your life. If you have one episode, the impact later on in life, it's extremely high. We can talk about suicide attempts, which is one of the highest risk factors for mortality during a youth, which is it's a very big number. So in that sense, we can't wait for youth to actually have any problems before we do something with them, we treat them. Actually, we need to prevent, because again, if they have the first occurrence of a problem, the likelihood of having a recurrence is extremely high. So we are working on promoting mental health, which goes beyond preventing mental health problems, because it's almost running after your tail. If we are talking about promotion of mental health, we are talking about equipping adolescents to progress with their life, to develop with their life, with the necessary tools to not have any mental health problems, because that's actually the key, to prevent the mental health problems. But life goes on, and adolescents go from different stages all the way to adulthood, early adulthood, and later on. So actually we need to equip them with tools to manage their life and to avoid having serious mental health problems. And actually it's quite complex, because adolescents are not alone in this, and that's also why in our approaches, in our projects, we are testing a very comprehensive approach, which the adolescent is the center of our focus, of course, but we are focusing on the entire ecosystem around the adolescent. So we are not just targeting or promoting or delivering contents for the adolescents, but also to the ecosystem of them. And since in high-income countries, the vast majority of children and adolescents, they are at school, in low and middle-income countries, a good proportion are also enrolled in schools. We use the school as the central point to disseminate the programs, the intervention. And also, the school period, it's a very important period for youth to develop tools. So one of our projects, the IMPROVA project, which you can follow the website, improvaproject.eu. In this project, we co-design, and this actually goes in line with our colleague Frédéric, who mentioned the importance of co-designing with the end users the solutions. We are co-designing an e-health platform to promote mental health for the adolescent. But of course, we have contents for the adolescents, but we include the entire ecosystem. So the teachers, other health school professionals, parents, and we have user-specific contents. So teachers receive tools on how to communicate better with the students, how to manage conflict with the students, how to improve the classes with the students. In one of our previous projects, we saw that providing pedagogical tools to physical education teachers actually decrease the risk of having depression, subclinical symptoms of depression, by 90%. Just with physical education teachers, focusing on a lifestyle behavior, on being more physically active. And a funny fact is, the effects were mediated by social isolation, meaning that the moment of the physical education lesson was actually a moment to connect with your peers, because the physiological effects of physical activity, they last a few days after the moment, but the relations you build in that moment, they actually go beyond those physiological effects. So in this project, in IMPROVA, we have contents for the teachers, to other school professionals like the school health psychologist or nutritionist or or any professional around the school, also the school directors, because the school directors, they are very important to support the changes that the teachers need to implement into the classes, after the classes. And we also include contents for the parents, with relationships with their offspring, also to early identify any problems, because if you identify early, you are able to do something before it becomes something more serious. And we are doing this in a way that it's adaptable to the needs of all of these users and characteristics. Because, for instance, it's not necessarily all teachers that need the same resources. Maybe one teacher needs more resource on how to communicate better with the students. Another teacher might need more pedagogical tools to engage students in their class more, to welcome students more. And this is only possible because we are implementing our solution using an e-health platform, because it's adaptable to the needs of each of those type of users. So I like to make an analogy. It's almost like we are presenting a menu from a restaurant, and then you pick what you need. So it's adaptable to the needs of each of those users. We are not going there with a fixed approach, because we are very different and people need different inputs and need different feedback. So that's also something I would like to highlight here, that it's not that we want adolescents to be more engaged with the screens, but they are not going to use screens more because we have an e-health platform. Actually, we need to show our presence there to take them out of the bad apps and bad screen behaviors and take them more into the offline life with their friends, with their family, with their colleagues, having fun and enjoying themselves. And another project, this is a project that we are having various types of contents, like for adolescents to manage their behavior, relationships, sexuality, their growing body, emotions, having resources on how to deal with their emotions. But there is another project that we are focusing more into lifestyle behaviors who have a very big impact, and they opening doors to other behaviors like physical activity and nutrition. And in this other project, we are focusing in these other two behaviors, and we are designing a tool hoping that this is adaptable to many different settings. So we are testing this platform in IMPROVA, not only in Spain, but also here in France, in Romania, and in Germany, to see whether our tool is adaptable to different ecosystems, because our hope is that IMPROVA would be a health tool integrated into the educational system to reach as many adolescents as possible, of course. That's the end goal. I think if I want to make a closure on my talk, I would like to highlight the need of being adaptable and promotion, and equipping students, adolescents, children, and also the ecosystem around them for a better life. Thank you.
Thank you very much, Rodrigo. So now we will move to the general discussion. And we will start with some exchange with the four of you. And then we will take questions from the audience. And we will keep a few minutes at the end for the conclusion together with you. So, first of all, thank you very much, because these very interesting and enriching testimonies clearly show the importance of the problem and its complexity. So first, I would like to ask all of you, which, in your opinion, is the absolute priority that would be the most urgent to address and to resolve. And I would like first to turn to Maria to get the point of view of a patient facing this situation daily. So please, Maria, can you start answering to what is for you the number one priority?
Yes, of course. the #1 priority for patients with HoFH, notably, is 6 factors that we can't separate. First of all is early screening, early detection through DNA tests and blood tests that would avoid kids having cardiovascular accident and hence mental health issues in their adult life. Second element, which is inseparable, is also having an efficient and personalized treatment for HoFH patient. These two goes along hand in hand. Because I was diagnosed very early, but I didn't have the good treatment. I ended up having a heart accident. So both of them are very important. Third element is having access, giving patient the access for the treatment that they need. I feel lucky in France. I have the treatment that I need, but it doesn't, it's not the case in all of the countries, and health shouldn't be a luxury. It shouldn't be a condition where if you live in this country that you are able to live. All countries should take care of their patients, especially who have chronic illness, because it is imposed on us and we don't have control over, which adds more and more anxiety and depression for our everyday life. Fifth and sixth elements are what Frédéric, Silvia, and Rodrigo talked about, are the follow-ups of the doctors and psychological health professional. When patients are followed by these professionals for their physical health and mental health, it alleviates their anxiety and depression and the burden of living with a chronic disease. So for me, those 6 elements are very crucial for patients with a chronic disease.
So Maria, if I understood well,
Yes.
the reason why you are living in France is not only because France is the most beautiful country in the world, but also because you think that the health system, the health organization fit quite well with your needs.
Exactly. And I am part of FHR Foundation to share my story, and maybe all the countries will have the same professionalism and care and medicine that I am provided in France.
So, thank you. Now I will turn perhaps to Frédéric. So at the EBC level, what is really, Frédéric, what you are really pushing, what is the first priority for the EBC?
Well, thanks, Alain, for that, because obviously it's a super timely question, given the fact that we are all invited to go and vote for the EU elections in a couple of weeks. So obviously it is a context for an organization like us really to reshape and reinforce a little bit our policy ask and obviously be a little bit ambitious there. But if I have one that I need to top up is really to make sure that we have a recognition of the urgency to tackle and to prioritize brain health as a policy priority and as a transversal policy priority. As I was saying in my introduction, we are not only looking at diseases, but also at the healthy brain, but also how healthy brains contribute to a healthy society. So it is really like a positive continuum there. But if we focus simply on the disease brain, you know, I mentioned a few figures about the number of people living with brain condition, but if we take it in relation to the global burden of all diseases, we are between half to 2/3 being related to a brain disorder. So this is really staggering, but not only it is staggering, but it is growing, because we know that the factor of growth of this burden is aging. And in a sense, we have an immense public health success in our beautiful European region. Sorry, Alain, I'll take your words, but extend it to Europe as a whole, but in our beautiful Europe. we have this fantastic success of public health, but it comes with a challenge and a responsibility. So for us, this prioritization is not to have it like as nice words in a big title on a nice policy paper, but it's really to make sure that we provide support to an ecosystemic effort. So it's really to make sure that all the tiers that are involved in the innovation generation actually receive the right support and the right incentives. And I would say that we create an innovation-friendly ecosystem in Europe so that we can address this challenge collectively and that we leverage impact and enabling solutions.
Thank you. So maybe now, Rodrigo, you can highlight what is really, we heard through your presentation what very likely is or are your priorities, but can you explain a little bit what really is for you key?
I think there are a few points we can mention here that I did not stress enough previously. One of the things I would like to highlight is that we need to be careful about only raising mental health awareness with youth, with children and adolescents, because they are already going in a very transformative phase, and only making them aware maybe on how sad or unknown and not really understood, that's actually just bringing to the surface a lot of things that are internally there, and actually this can be a trigger for problems. So we need to go a step further than that. Mental health awareness, educational campaigns, we need to be very careful about this because we need to equip them and the system around them actually to go 2 steps ahead. One thing is to be aware on your feelings and your behaviors, but we need to go further and how to deal with them and how to deal with our emotions, how to deal with this transformative moment in life, how to deal with our relationships. So this, I think, it's one of the key aspects. And to be able to do that, we need adaptable programs, tools, resources. And that's also why we think we are going very strongly into co-creating e-health platforms, because in comparison to offline programs that you have to go to the schools to implement into the system, you can update the program because the needs change. What the adolescents need, they are different. There are circumstantial contexts that you can't foresee, but if you have an online program and tool integrated in the entire system with users and the system, educational system, health system, actually you can update the program and implement almost instantaneously and reach them in a much more efficient way.
And Rodrigo, do you have specific programs corresponding to the different situation, to the different environment, diseases, or age, for instance?
It needs to be, you mentioned something very important, it needs to be also age-specific. So IMPROVA is focusing on secondary school adolescents from 11 to 12 years old, and that there is a reason for that. We incorporate our lifestyle behaviors during childhood, and actually when they are concrete, sustained, and incorporated for life, it's early during adolescence. So that's a key changing moment to work with mental health promotions. We do have this project, which is initially a research project, but it's also implementation project, because by the end of the project, we will design concrete policy programs. We will translate all of this knowledge from the project into policies to implement the program in real life, in community life. The program has been conceptualized with this in mind, so from the beginning of the concept of the project all the way to reach the system and users and students, and for that reason we are including already now policymakers, and we are testing the platform in this concept now in September. We are starting the testing, so we do not have a concrete tool ready to be launched. We are finalizing the final steps of the program, and in September we are going to test in parallel in 4 different environments: in France, in Spain, in Germany, and in Romania. And we hope to learn how the different systems, they need the platform differently. And since our program is not a fixed program, so for instance, there is not one single tool that we require teachers to implement them. Actually, we offer a lot of resources. We hope to equip them with resources, and they use as they come. And we have a lot of implementation measures to understand how this platform was used in different systems, so we can actually develop further and implement it further in different ecosystems, and hoping to reach as many adolescents as possible, because it's various. We have various needs in the adolescent level, at school level. If we only talk about socioeconomic differences, this is already enough. But we have cultural differences in Europe, so it's extremely complex. So we need to be context, cultural, and age-specific in our program. So the task is actually extremely complex.
You spoke about adolescent in the school environment, but what happened when these young people, they are moving from student life to active life?
That's another change.
And it can be also a question for Frédéric. Do we have specific program in order to bridge the two very different environment? It's not at all the same when you are a student and when you are starting in the adult life.
Yes. There is one, I can mention one program from USA, University of Texas. They are focusing on equipping the mindset of these old adolescents to college. So this exactly this transition, and they are having extremely impressive results on helping historically socially disadvantaged adolescents or young adults to finish college with a profile to go to higher education. And actually their program have impacts actually as long as 4 years after the implementation of the program. So this would be one that I would highlight, focusing on changing the mindset about specific aspects, about your intelligence, for instance. That is something you can nurture and develop instead of having this fixed idea of IQ, that you have a number that summarizes your capabilities.
Frédéric, you would like to add something?
Well, I just wanted to maybe say a word about this notion of continuity. I mean, we have made work on the notion of continuity of care, but here I would probably call it continuity of promotion and prevention. Because as Rodrigo was saying, it's all very nice to have, I mean, tools and information systems that actually do promote or talk about mental health, so that we realize the importance of it. But it should certainly not be a problem generation. It should rather be a kind of an awareness raising. But then it needs to be accompanied with like proper tools, proper solutions, proper guidance, and resources. And what we have seen and what we have worked upon was more workplace-related tools of that kind. Because there is definitely a great demand over there. But what we bumped into was a little bit more an issue from the employer side of, I would probably call it meaningfulness or coherence, because some were basically using those tools more as a lip service to say, oh, look, we tick the box of we've done the work for mental health for employees, and then let's move on for next employer's obligation. But in the culture of the organization, it didn't change. It didn't change really much. So here there is probably a need to have that holistic and inclusive approach, but I would say at all levels in society. And Rodrigo, I very much liked what you said about engaging teachers or engaging those who are really close to kids, adolescents, and even young adults, because they need to realize what it is in terms of like what is the mental pressure from their studies, but what is also mental pressure from their private life that is going to impact their productivity and their well-being. And the same goes for young workers, and the same goes for workers at all age. So it is probably this kind of more holistic and transversal approach that is necessary.
Thank you.
Alain, if I jump in here, because sadly we are limited for time, have we got questions coming in from the
I
in
would
the
like,
chat?
Before moving to the question,
Lovely. Okay, fantastic.
From the attendees, I would like to give Silvia the opportunity to tell us about priority. Silvia, you describe very comprehensively, very extensively, the discovery program, which is a very ambitious one. I would like to understand what do you learn during the recruitment period, and what are you really expecting next year from the results?
Right. After observing the significant impact of mental health on patients with irritable bowel syndrome, I mean, most of them, they come with very high levels of stress, anxiety, depression, which makes all the symptoms, their gastrointestinal symptoms, worse. So there's what we've learned so far is that there is an important, a considerable need for integrated care approaches that address both, as Maria said before, the physical and the psychological aspects of not only IBS, but other chronic diseases. The thing is that traditional treatments often focus only on IBS. This was the case on their gastrointestinal symptoms, and they neglected the underlying mental health component. So it was not really like interconnected. So I think the recruitment phase has highlighted the importance of adopting, as Frédéric said, a more holistic approach that considers interconnecting both physical and mental health in managing the IBS. In the recruitment phase, I recognize also the challenges that patients face when seeking the appropriate care and support for their condition, because there's still a lot of stigma surrounding mental health issues, and with IBS there's still a lot of like misunderstanding and misconceptions. So you know, we need to make plans and you know, focus on raising awareness and education. There's stigmatized efforts, you know, within both the healthcare community and society. So I think by gaining a deeper understanding of the complex relationship of the gut, in this case IBS, and mental health, we will be able to develop more tailored and effective interventions. And these will include personalized treatment plans that address both the symptoms and psychological, you know, distress, as well as interventions aimed at reducing the stigma and improving the access to care. So basically, you know, by raising this awareness, I think we can provide the patients with, you know, a better lifestyle in general, and that's my opinion.
Silvia, thank you very much. We have still a few seconds for one or two questions from the audience. I have a question which is, are there any countries more concerned than others? And is this due to better prevention of mental health? So very briefly, who would like to answer about these differences between potential differences and commitment?
Well, I mean, maybe I can take that. I think that, I mean, the trends are probably similar across countries. when it comes to the burden and the impact to society. But I believe that, I mean, as Rodrigo was mentioning, interventions or the solutions as they are being put in place probably take shape in very different ways, depending on, I would say the microcosm of different countries or different regions. I was presenting this example of the Brain Health Data Hub, starting with 4 or 5 countries. Why others didn't follow? It's a question of maturity. It's a question of buy-in. It's a question of engagement. But we have already a few countries that are ready to knock at the door. So I think what we need to maintain is a mechanism by which we can learn from good practices, or we can learn from those initiatives, and we find ways of transferring them. So, or maybe learning from each other. So having this kind of engagement is probably what is paramount.
Okay. So I think we have definitively to stop, unfortunately, because I was having some additional question. Just briefly, Rodrigo, can you answer one word? I have a question. Do we really see an increasing number of young people struggling with mental health since the COVID? Yes or no?
Yes, we see this data showing an increase in mental health problems after COVID. Yeah, unfortunately.
So thank you so much, Alan, Rodrigo, Frédéric, Maria, Silvia. Thank you so much for this extremely interesting and extremely important discussion, which has only really just begun. We could certainly continue much further this afternoon. And we're going to do just that. We're going to have a short break. We're then going to pick up with our second roundtable, looking at how environment in this challenging world impacts our mental health. So stay with us for that. Thank you once again, Alain, and all the speakers. Thank you.
Thank you.